So we go on to our next speaker, Dr. Vishal Govindahari, who's a consultant Vitro Retina and UVR services at LVPI Bhubaneswar, with his area of main clinical interest in diseases of macula, myopia, and newer imaging modalities. He would be discussing a case of retinitis pigmentosa. On to you, doctor.
Yeah, thank you, Vishal. I think now he is the consultant at Pushpagiri Vitro Retina Institute at Hyderabad. Over to Dr. Vishal.
I'm so sorry.
Thank you, Chitrana.
I should have asked you.
Thank you, Srinivas sir, for the opportunity. Instead of a routine case, I just wanted to highlight the important checkpoints at a given case presentation of retinitis pigmentosa. Considering
Vishal, your voice is very feeble. I don't know if I am hearing that.
Now? Can you hear me now?
No, little more louder, please.
Can you hear me now?
Yeah. Much better.
Much better now.
Yeah. So I would just be looking at the important checkpoints during the case presentation as opposed to presenting a case, because I had discussed with Srinivas sir and he had given me the freedom of discussing what is important. So considering 5 minutes, here is what I have to present. With respect to demographics and retinitis pigmentosa, what is very important with respect to age is the majority present between the 2nd to 3rd decade. And the inheritance patterns actually influence the age of onset, while Leber's is a juvenile variant. And with respect to gender, you have the X-linked recessive affecting predominantly males. Presenting symptoms invariably include first being night blindness, followed by poor vision, eye ache, and deafness. Visual impairment is more severe in the X-linked recessive variant rather than autosomal recessive compared to autosomal dominant. Photophobia appears later in the clinical spectrum. Contrast sensitivity gets affected, and dyschromatopsia also gets affected in case of macular involvement. History of present illness is important because it's a very insidious onset invariably. It has a very gradual progression. Specific complaints with respect to dim light or night activities in early stages. Difficulty in driving or activities dependent on visual fields, and no diurnal variation impairment as age progresses. Family history is very key. The involved family member, whether parent, sibling, uncle, aunt, or grandparent, and the importance of parental consanguinity, as you can see the degrees according to the National Health Scheme of the UK. The mode of inheritance on the right gives you the simplex, that is the sporadic variant, versus the percentages of different kinds of inheritance. Pedigree charting, which is expected in an RP case. Just to simplify it, dominance versus recessive, there's always a skip noted in recessive. Autosomal versus sex-linked, father-to-son transmission happens only in autosomal. Y-linked, only males are affected. Mitochondrial disorders, mothers alone transmit the phenotype. X-linked dominant, fathers do not transmit to sons, and X-linked recessive, males are more commonly affected. So this is just a quick representation on how to show the pedigree charting. And this is how dominant, where there is no skip. In recessive, there is a skip. X-linked dominant, where fathers don't transmit to sons, and the X-linked recessive, where males are predominantly involved. Smoking and alcoholism are known to worsen, especially smoking, and a combination can lead to lung cancers in case of vitamin A therapy. Systemic history is extremely important considering syndromic associations, ushers with deafness, and Bardet-Biedl presenting with the obesity, psychomotor delay, hypogenitalia, renal abnormalities, and neurogenitary changes. There are a whole host of other diseases like Alport's, cocaine's, A-beta lipoproteinemia, mucopolysaccharidosis. These are quite academic, but at least knowing one sign like Alport's nephritis, A-beta lipoproteinemia having steatorrhea, and BTs having corneal crystals are something which is expected. These are the mitochondrial deficiencies, which disorders which are associated with pigmentary retinopathies. Kearns-Sayre, NARP, and MELAS are the 3 things which are essential. There are a whole host of other associations which are for us to remember if required. This is the picture with Bardet-Biedl, where you have polydactyly and hypogenitalia, while this is a patient with ushers. In case of visual assessment, you do an uncorrected and best corrected. Color vision gets important in case of optic nerve involvement, and the low contrast visual acuity to assess the macular involvement. Nystagmus in case of LCA, RAPD as discussed can occur also in LCA. Extraocular movements in case of mitochondrial involvement, and a thorough slit lamp examination. You have these ocular associations like keratoconus, posterior subcapsular cataracts, and disc drusen. With the fundus, you have the early stage having, apparently featureless retina. Over time, you can see the atrophy coming in, the retinal atrophy with the macula being spared, and in the final stage having all the 3 symptoms of waxy disc, attenuated vessels, and bony spicules. CME, cystoid macular edema, epiretinal membranes, and traction are a common association. A differential diagnosis of gyrate, choroideremia, or cone rod dystrophy have to be mentioned. Some infectious pigmentary causes also form the differential, like syphilis and DUSN. There are some atypical variants like albipunctatus and the sign pigmento or the sectoral RP, which also have to be known when you are giving your final diagnosis. Among the investigations, unless and until you have a diagnostic dilemma, ERG can pick it up, but if you already have a diagnosis, it's not needed. As shown, early phases where the fundus doesn't show much is the ERG which gives you the diagnosis, but with progression, the photopic response also gets affected. As you can see, the HVF initial scotomas around the 20 degrees, which start to close in on the tunnel, which constricts over time. OCT is being used nowadays to assess cystoid macular edema, to understand traction, and to assess foveal atrophy. Dark adaptometry and EOG are seldom used. Autofluorescence is one thing which I would add to understand the progression over years with the Robson's ring, and a multifocal ERG in case of vision not explained by the grade of atrophy. Genetic analysis becomes key to identify the particular mutation and the risk of transmission to offspring, to understand the clinical cause and whether they're eligible for gene therapy or not with respect to availability of therapy. There are a whole host of genes involved with is the most common one. I'll just take a minute. The final diagnosis should ideally be mentioned a rod cone dystrophy rather than RP. Likely to be RP is a better way to put it. Mentioning the atypical variants and systemic associations in the final diagnosis is essential. Quick treatment view is just to assess for cataracts, macular edema, and providing low vision aids. Vitamin A has been tried along with docosahexaenoic acid, but of limited value. Gene therapy, photoreceptor cell death therapy, and retinal implants are the way to go with respect to what is expected as future prospects with retinitis pigmentosa. Thank you.
Very good presentation.
Thank you, Dr. Vishal. I think you gave an overall glimpse, but I would like to ask Dr. Guruprasad sir, whenever this question comes, a case comes to the postgraduate, what are the must things that he has to answer and he has to know for him to just pass out this?
Yeah, I think you should not have given him the liberty of presenting it differently. He has taken away my job.
He has mentioned it as liberty, so he has taken it. No worries. Go ahead.
So yeah, I'll probably restrict myself to what the questions might be asked. I think they might ask, what are the causes of night blind? What are the causes of night blindness? So I think candidates should be very familiar with what are the causes of night blindness, like vitamin A deficiency, myopia, glaucoma, cataract, cirrhosis, and all those things. Then the question will come whether is dealing with a primary pigmentary degeneration or a secondary pigmentary degeneration. So I think age comes to the rescue. If the patient is young, then probably it's a secondary one. Primary is usually the ones which are inherited either sporadically, it's either sporadic or inherited autosomal dominantly or recessively or X-linked, and therefore because the sporadic ones are the most common, probably the primary ones are the most sporadic ones. If it is elderly, then probably the differential diagnosis of paraneoplastic disease will probably come, ophthalmic artery occlusion. And other thing, he already mentioned the differential diagnosis of diffuse uveitis, syphilis, paraneoplastic syndromes. I think that I don't know whether he mentioned that scar and mar can present in the elderly as a sudden onset of night blindness and loss of vision. Did you mention that, Dr. Govindahari?
I did not mention that.
Okay, so that is one differential diagnosis. Drug toxicity is another thing. Cirrhosis is one thing that can masquerade as retinitis pigmentosa, spontaneously reattached retinal detachment, and DUSN. I think these are the things which can be listed in the differential diagnosis of retinitis pigmentosa. ERG, I think it's important to know what the ERG findings are in a patient with retinitis pigmentosa, and it's important to know that even carriers can have B wave delay. And the variants you already told, the sectoral ones involving 1 or 2 quadrants, central RP, pericentral RP, unilateral RP, all these things are some things, certain things that should be known by the candidate. I think the other things you have mentioned very well, the syndromic associations, the secondary ones. Basically what primary means is that retinitis pigmentosa, which is not associated with any systemic illness or systemic syndrome, and second is the one which is associated with the syndromic associations, Bardet Beetle, which is, yeah, like he listed out very well, at least one characteristic of each of these syndromic associations one should know. I think he has done a very good job in presenting the case and also telling about what is important in the presentation, what one should know. I think there's not much for me to add to what Dr. Govindahari already has told. Yeah.
Thank you, Guru Prasad sir, for that viewpoints, which I think the postgraduate must know to pass in any case given as retinitis pigmentosa. And overall view has been given very nicely by Vishal. Thank you, Vishal. Thank you, Guru sir. We'll go ahead with the next talk.
Dr. Srinivas, can I just make a quick point
please,
here?
please.
I think the whole objective of this session it was quite clear, but I have a small disagreement that it should be just to pass exams. I think the main focus should be how would you approach a case when you are sitting alone in an OPD without any help. That is how, if you see picture yourself in that situation as a postgraduate and you prepare for that situation, you will not only pass exams with flying colors, but you will also become a good clinician. So
Yeah,
just for any case presentation, not just these four, but any case presentation, I think your history should include the features that you are probably ending up, the diagnosis which you are ending up with, that is to establish the diagnosis, the factors that you are going to establish the diagnosis, then the factors that are going to give you a differential diagnosis, and also to include the atypical features of a disease that you are actually going to discuss in the end. The examination should be comprehensive, starting from anterior to posterior, not excluding extraocular movements or adnexa or anything. That is mainly to look for any comorbidities that one disease may have. A diabetic patient may have sixth-nerve palsy, as Dr. Talwar had already mentioned. So just not to exclude any or miss out any comorbidities, but also to include or pick up diseases which are coexistent with the disease that is being presented. So you may have one case with multiple factors or multiple disease, like a diabetes with glaucoma or diabetes with any other coexistent problem. And the end, if you reach the diagnosis, you have already passed most of the cases. I mean, which I have come across. If you have reached the diagnosis without much of like flumming around, so you have already passed exam, then you have to just propose the differential diagnosis, and whenever possible, put a differential diagnosis. Unless it is very clear-cut, discrete diagnosis like retinal detachment, give a differential diagnosis whenever possible. So once you have reached that stage, then it is all theory, and whatever is your knowledge you have read through, it will take you through. That's it.
Yes, and one freaky examiner can even ask you what is treatable retinitis pigmentosa, and you should have an answer for that.